Greetings. I'm thrilled and excited to be part of this grand rounds on the cardiac device infections, which is a collaboration between the Cardiology Society of India and the Clinical Infectious Diseases Society. Hi, I'm Dr. Neha Gupta, infectious diseases specialist from the first batch of FNB infectious diseases, and I'm attached with Fortis Memorial Research Institute, Gurugram, and founder of NG Swasta, which is our infectious diseases and vaccination clinic. I would like to begin with acknowledgement to my mentors, Dr. Rajiv Soman sir and Dr. Kamala Rodriguez ma'am, for empowering us. So, as we are discussing the cardiac device infections today, the developing world has an unusual combination of factors which is responsible for the intravascular stent-related infective endocarditis and endarteritis, and I'm going to highlight these. This is a 51-year-old gentleman who had undergone PTCA of the LAD, and then 4 weeks later, he developed fever. Subsequently, he also developed cough as well as the skin nodules. Later on, he was diagnosed to have coronary blockage on the coronary angiography, and as we can see here, the stent was lying in the LAD aneurysm. The blood cultures were positive for the AFB, which were identified as M abscesses. And at this point, infectious diseases opinion was sought. This was almost 18 months after the initial onset of symptoms, indicating the delay in the diagnosis of this patient. He was initiated on clarithromycin, moxifloxacin, and linezolid. The plan was to do stent removal, but the patient died before the surgery could be done. Another patient who had undergone PTCA of the LAD elsewhere, 1 month later presented with fever. The blood cultures were positive. He also had vegetation at the mitral valve, so was diagnosed with NTM infective endocarditis, for which he was treated with MVR and also received imipenem, ciprofloxacin, amikacin for 3 months. During this he improved and was discharged, but 3 months later he presented with fever, congestive cardiac failure, anemia, recurrent NTM bacteremia, and also there was recurrence of the prostatic valve endocarditis at the mitral valve, as well as a new vegetation at the aortic valve. The blood cultures were positive. The culture grew AFB bacilli, which were identified as Mycobacterium chiloni, which is a rapidly growing mycobacteria, and with the following susceptibility, susceptible to moxi, clarithromycin, and imipenem. And as notably we can see, the first line anti-TB drugs are all resistant. They do not work for the NTM, RGM, that is RGM mycobacteria. So what is the likely cause of infection in this patient? Is it the immunocompromised status of the patient which is leading to NTM bacteremia and has seeded the prostatic valve? Poor dental hygiene of the patient? Reuse of single-use angioplastic balloon that may have been inadequately sterilized, or any of the above? So what about the immunocompromised status? The patient is not that immunocompromised. NTM infections can happen in patients who are having HIV. So MAC is possible in a HIV patient, but the presentation is different. It's with abdominal pain and diarrhea and not with a bloodstream infection. What about poor dental hygiene? NTM are not part of the oral flora, which can give rise to eye. The infective endocarditis or the NTM bacteremia in this patient is because of the reuse of the single-use angioplastic balloons, and that which may have been inadequately sterilized. And this is probably the most likely cause. NTM are the water-related organisms, and they may resist many disinfectants, including chlorine as well as the aldehyde-based solutions. So this patient underwent coronary angiography, and it was found that the LAD was blocked. He was treated with clarithromycin, amikacin, imipenem, as well as moxifloxacin. CABG was done. MVR, AVR was also performed after 7 days, but stent removal could not be done because it was thought to be a risky procedure. Subsequently, post-operatively, immediately patient developed a very large stroke. When we looked at the excised valve, that showed granulomas and occasional AFBs were also seen. The valve culture as well as the 3 weeks post-operative blood culture remained positive for the NTM. The patient died subsequently. So this was persistent mycobacteremia. And what is the cause of this persistent mycobacteremia? Is it the lack of efficacy of the antibiotics, lack of source control, any of the above, none of the above? The correct answer is the lack of source control. So here, whenever there's stent, that which is the likely source of the infection, it also has biofilm, and antibiotics may achieve very little until the source is removed. The cardiac surgeon had considered removal of the stent, but it was thought to be a very risky venture and he refrained from doing so. The antibiotics which were given as per the susceptibility. They should have worked, but in the absence of source control, nothing would really work. So, what about NTM infections? NTM infections, like any other infectious diseases, they can present with different phases, and for good outcome, it's important to suspect early. So, when we discuss NTM infections, they can present as major clinical syndromes, including pulmonary and extrapulmonary. And here we have pulmonary, cervical lymphadenitis, skin and soft tissue, skeletal, bone and joint infections as the major clinical syndromes. In patients who are immunocompromised, disseminated infections with MAC and cancer are also possible. But NTM infections can also present as bloodstream infections following cardiac device related procedures. And these are usually caused by the rapidly growing mycobacteria, which is Abscessus fortuitum cheloני predominantly. And this is our experience with the intravascular stent-related endocarditis due to rapidly growing mycobacteria, which was published almost a decade back as a new problem in the developing world in JAPI in 2015. So we had close to 5 cases of rapidly growing mycobacteria, and it's important to note that the temporal onset or the onset of symptoms was 4 to 8 weeks following the PTCA, which is different from the other typical pathogens which are associated with endocarditis or even stent-related endarthritis, where like pathogens with Staph aureus, gram-negative bacteria, Enterobacteriaceae, Pseudomonas, they will have a more acute onset or a rapid onset following the procedure, but NTM infections usually present a little later. So how should we suspect them? So it's important to look into the symptoms, and usually symptoms begin 1 to 2 months after the index procedure. Any patient who's coming with fever with chills, loss of weight, appetite, anemia, features of congestive cardiac failure, skin nodules, splenic abscesses, vegetations at the valve, we should suspect endarthritis or an intravascular stent related infection in such patients. Cardiovascular device-related infections due to rapidly growing mycobacteria can also occur following the LVAD as well as the CI other implantable devices. And it has also been mentioned following the aortic stenting as well as in this particular recent publication. Now, how do we diagnose? So diagnosis is as per the battery of tests, which includes following the clinical suspicion, performing certain blood tests, including CBC, ESR, and CRP, which will be raised, performing an echocardiography, which will show the vegetation, a CT angiography or a coronary angiography, which can detect the status of the stent, the radiology, the FDG PET, the microbiology with appropriate blood cultures, and of course, histopathology of the excised valve or the tissue specimen. Microbiology is extremely important in the diagnosis, and here the blood cultures need to be sent in the appropriate volume. So it should be at least 3 sets, at least half an hour apart. And if you're suspecting NTM infections there, instead of the aerobic and anaerobic blood cultures, we can also send mycoaphilitic blood cultures, which will help in better isolation of the NTM or the rapidly growing mycobacteria. Now, RGM can also grow in the aerobic blood culture bottles, and NTM infections are classified as rapidly growing and slow growing based on their growth rate, morphology, and pigmentation. When we say rapidly growing mycobacteria, which are usually the cause for stent-related infections, they are not that rapidly growing, but they grow within 7 days. So there may be a delay in the growth as compared to the traditional typical pathogens, which usually grow within 2 to 3 days. It may grow up till 7 days, and that is why it's important to communicate with the microbiologist and also keep the cultures for prolonged incubation. Now, when a blood culture beeps positive, then these organisms can be seen on the gram stain as gram-positive beaded rods. With this, there should be a suspicion for NTM, and hence AFB stain is performed, which shows AFB positive bacilli. And with this, a rapid test, MPT64, can be done, which can help us in differentiating or identifying the NTM bacteria. In today's era, of course, with the positive blood culture, we can also perform MALDI-TOF for the correct ID. Now, there is also NTM PCR which is available, but that cannot be done from the blood specimens. So hence we have to rely on the AFB positive stain, the rapid MPT64 antigen, the MALDI-TOF, and subsequently it needs to be sent. It has proper ID as well as drug susceptibility testing needs to be done through the broth microdilution method. Coming to the management, how do we manage? So basically it has to be done with appropriate surgical source control is very important. Entire removal of the foreign body, the infected stent, as well as the vegetation, and also effective antimicrobial therapy needs to be given, which should cover the rapidly growing mycobacteria. And remember, the HRZE, which is used for treating tuberculosis, has no activity against the RGM. So what do we use? So non-tuberculous mycobacteria are not far behind in resistance, and this is our data which we had presented in SITSCON 2012, and which showed that the NTM has lost its susceptibility to the various other antibiotics, and the only few antibiotic options are amikacin, linezolid, and clarithromycin. We also have recent data from, again, Hinduja Hospital from the infectious diseases and the microbiology department. This is from Dr. Irfana and Dr. Aisha Sunawala, who they have also shown in their series that the treatment options are very limited, with amikacin, linezolid, and clarithromycin as the only treatment options, whereas in few of the cases, of course, we can have treatment options as imipenem as well as ciprofloxacin, but it's only 20 to 30%, which may be susceptible. Is there any difference in the susceptibilities among the various species of the rapidly growing mycobacteria? Yeah, so M. abscessus, fortuitum, as well as Chilone, they have differential susceptibilities. So for amikacin, linezolid, and clarithromycin, the susceptibilities are almost similar, but for moxifloxacin as well as ciprofloxacin, Mycobacterium abscessus as well as Chilone, they have very low susceptibility, and it's only fortuitum which may be susceptible. So moxi-ciprofloxacin can be used for the treatment of fortuitum, but may not be good options for treating abscesses and Chilone, and these then become much more life-threatening infections. So, in principle, for treatment of rapidly growing mycobacteria, at least 3 drugs to which the NTM is susceptible should be used. Amikacin is potentially combined with linezolid and clarithromycin, and alternatives like clofazimine, if there is intolerance or resistance to any of these, can be also considered. Bedaquiline is also an oral agent which has activity against rapidly growing mycobacteria. Treatment duration will depend upon the site of infection as well as on the valvular involvement, and may extend from weeks to at least 1 year of treatment. And more importantly, the treatment of RGM is individualized based on the tolerability of these medications. Coming to prevention. Prevention here, infection control for the rapidly growing mycobacteria is of immense importance. RGM is a waterborne infection and is resistant to chlorine and aldehyde. So sometimes the jet cleaning of the instruments and inappropriate infection control practices with 2% glutaraldehyde may be the reason behind these infections. And of course, single reuse of angioplastic balloons may also be the reason behind the stent-related RGM endarteritis or bloodstream infections. To summarize, cardiovascular device infections are life-threatening because of RGM, and early suspicion and optimized management and infection control practices for prevention of these infections is of great importance. And it's important to collaborate with different specialties with radiology, microbiology, histopathology for management of and infectious diseases for management of such complex infections. Thank you so much.